Welcome back, everyone, to another explainer. I am absolutely pumped to have you here today because we're embarking on a truly fascinating journey into the pure precision of modern surgical pain management. We're looking at the evolution of truncal blocks. Now, if you've ever stopped to wonder how modern medicine actually manages to keep patients comfortable after massive surgeries without relying entirely on heavy opioids, well, you're exactly in the right place. We're going to break down the incredible anatomical science and the imaging technology that makes this whole thing possible. So let's kick things off with a pretty massive clinical challenge, right? How exactly do you numb the chest, the back, or the abdomen without using an epidural? For decades, thoracic epidurals were basically the gold standard for managing severe pain from trunk surgeries. But what if an epidural is contraindicated? What if the patient is on anticoagulant therapy, or an epidural just isn't an option? We need alternatives that provide really robust, reliable pain relief, and the incredible solutions we're about to explore have completely transformed perioperative care. Okay, let's dive into this. We are talking about a massive historical shift in regional anesthesia here. For a very long time, practitioners had to rely on traditional landmark techniques. This meant literally physically feeling for bones, aiming a needle blindly, and relying on really subtle physical feedback, like a little click or a pop, as the needle passed through a ligament or a fascia. It was definitely an art form, but it completely lacked direct visibility. Today, the vast majority of these blocks are performed using modern ultrasound guidance. So instead of feeling in the dark, practitioners are seeing the anatomy, the surrounding organs, and the needle tip in real time on a screen. It's a total game changer for precision and safety. So here's our clear roadmap for today. We'll start with number 1, the Ultrasound Revolution. 2, Thoracic and Chest Wall Blocks. 3, Abdominal Wall Blocks. 4, Posterior and Back Blocks. And finally, number 5, Risks and Complications. All right, seamlessly jumping right into section 1, the Ultrasound Revolution, the tech foundation of it all. To really grasp truncal blocks, we've got to understand the whole map and territory metaphor. Most upper and lower extremity blocks target specific nerve roots, but truncal blocks, they're a bit different. They largely target what we call fascial planes. Think of these as hidden highways situated perfectly between different muscle layers. The local anesthetic is deposited directly into these interfascial planes, and it just naturally travels along these highways to bathe the nerves coursing through them. Ultrasound basically acts as our high-definition GPS, allowing us to navigate right to these precise highways, rather than aiming for specific nerve roots. It means completely leaving behind the guesswork of the past. Moving right along to our first anatomical stop in section 2, thoracic and chest wall blocks. This is the start of our top-down anatomy tour. First up, the paravertebral nerve block, which is commonly referred to as a unilateral epidural. It targets the spinal nerves on just one side, which makes it absolutely excellent for thoracic surgery or rib fractures. Now, what's really interesting about this slide is the delicate boundary of the pleura. That's the membrane covering the lungs, which sits right near the paravertebral space. With ultrasound, you can actually watch the real-time downward displacement of the pleura as the local anesthetic is injected. That confirms perfect, safe placement. Swinging around to the anterior chest, we have the pectoralis or Pecs blocks. These have completely revolutionized analgesia for breast surgeries, pacemakers, and portacath insertions. They offer a much simpler, significantly safer alternative to thoracic epidurals. And crucially, this is a big deal. Unlike epidurals, they lack the sympathetic nerve block effect. That means they don't cause those dangerous drops in blood pressure, making them highly desirable for patients. When we break down the precise needle approaches, it's like a brilliantly layered puzzle. The Pecs I block targets the plane right between the pectoralis major and minor muscles, catching the medial and lateral pectoral nerves. Then, the Pecs II block goes one step further, one layer deeper, actually, sliding into the plane between the pectoralis minor and the serratus anterior muscles. This deeper injection spreads that pain relief all the way into the axilla and the upper intercostal nerves. Because we are working in highly vascularized intermuscular planes here, a universal safety protocol is absolutely vital. You're going to see this rhythm over and over in modern anesthesia. Place your high-frequency transducer, insert the needle in plane so you can see the entire shaft, always confirm negative aspiration to ensure you aren't in a blood vessel, and finally, inject in careful 5 ml increments. Let's repeat that for emphasis. Always confirm negative aspiration, followed by 5 ml increments. That rhythm is literally the heartbeat of safe practice. Okay, let's head southward. Section 3, abdominal wall nerve blocks, focusing on mid to low surgeries. If the abdomen had a superhero, it would absolutely be the transversus abdominis plane, or TAP block. It's a vital multimodal analgesic alternative for mid to low abdominal surgeries. Think hernia repairs, appendectomies, and C-sections. The target here is the fascial plane tucked right between the internal oblique muscle and the transversus abdominis muscle. By depositing anesthetic into this exact specific layer, you effectively block the thoracolumbar nerves supplying the abdominal wall. And this brilliantly illustrates just how incredibly versatile the TAPE block is. By simply sliding the ultrasound transducer to different parts of the abdomen, you dictate exactly what coverage you get. A subcostal approach provides analgesia for supraumbilical surgeries, meaning above the belly button. Sliding laterally or posteriorly provides reliable analgesia for procedures below the umbilicus. It's one foundational technique adapted purely by where you place the probe. Now, for surgeries that require a direct midline incision, like, say, an umbilical hernia repair, which is super common in pediatric patients, we rely on the rectus sheath block. Briefly, for these midline cuts, the targeted solution is advancing the needle through the rectus abdominis muscle belly and injecting directly into the fascia right against the firm posterior rectus sheath. Wrapping our anatomical tour around to the back of the patient now, Section 4, posterior and back blocks. To hit those deeper abdominal nerves from the back, we use the quadratus lumborum, or QL block. And this features nature's little anatomical Easter egg, this shamrock sign. It's such a fun visual mnemonic. When doing a QL3 block, the practitioner uses a curvilinear transducer to find this exact image. The transverse process of the L4 vertebra creates a dark stem, while the erector spinae, the quadratus lumborum, and the psoas muscles cluster around it perfectly, just like the three leaves of a shamrock. It makes locating the muscle highly memorable. Let's move to and see how this builds in an actual clinical setting. Notice how the transducer is positioned to capture that exact shamrock geometry. The needle is then passed through the quadratus lumborum muscle directly into the inner fascial plane between it and the psoas muscle. Doing this avoids the recess between the abdominal wall and psoas major, which theoretically reduces the risk of injecting into the peritoneal cavity. Also on the back, we have the incredibly versatile erector spinae, or ESP block. Now this one is deceptively simple. The needle is inserted until it actually contacts the transverse process, and the anesthetic is injected deep to the erector spinae muscle. Because the fluid spreads so significantly up and down this plane, a single injection provides vast multidermatome coverage by targeting the dorsal rami. It's used for everything from back surgery to rib fractures. All right, as incredible as all this technology is, let's adopt a more measured tone for a second. Section 5. Risks and complications. Vigilance is absolutely essential here. So the crucial point is this. While ultrasound-guided truncal blocks are generally much safer than traditional epidurals, they demand intense vigilance. Because we are filling large highways or fascial planes rather than targeting a single tiny nerve root, these blocks require large volumes of local anesthetic. This puts the patient at a very real clinical danger for last: local anesthetic systemic toxicity. Plus, because we are working so incredibly close to the lungs with blocks like the paravertebral or Pecs II, a pneumothorax is a potential threat. Inadvertent vascular injections and simple block failures are also major concerns if you choose the incorrect fascial plane. Because of these large volume requirements, we have to bring back our rhythmic repetition for one final, vital reminder. To avoid these risks, especially vascular injection and systemic toxicity, always perform negative aspiration, followed by incremental 5mm injections. It allows the practitioner to monitor the patient's reaction and visually confirm the spread of the medication safely. Negative aspiration, 5ml increments. Which brings us to the end of our anatomical journey today. The shift from blindly feeling for physical landmarks to utilizing real-time, high-definition ultrasound has profoundly changed how we manage pain. It's making recovery faster and safer for millions of people. But it leaves us with a pretty thrilling thought. As ultrasound technology continues to advance, becoming even more portable and high-resolution, what new, hidden anatomical highways will this precision unlock next? Thank you so much for joining me on this explainer. Keep learning, stay focused, and I'll see you next time.